everyone, welcome. My name is Mindy, and I'm going to be doing the AMI Perfuse STEMI Cath Lab orientation today. I am the program manager here at Maine Health, Maine Medical Center in Portland, and I'm looking forward to getting to interact with you guys and teach you a little bit about our STEMI care. It looks like we have quite a few people on today. I do want to let you guys know that this is available for credits and that I do not have any disclosures. Um, with that being said, I would love it if we could put your name in the chat and your department, how long you've been a paramedic, and if you've ever activated the cath lab. I know that with Eric sending this out statewide more than just Southern, we may find that we have people that are not going to transport people directly to Maine Medical Center. So, and this original training was for directly to Maine Medical Center. But I'm going to improvise a little. And so knowing where you guys are coming from will kind of help me a little bit. So I see Bath, and if you can just put your department as well, that'd be great. Brunswick. Awesome. Bath, Brunswick. We have a lot of Bath and Brunswick people. Welcome. Gorham. Awesome. Well, once again, I'm Mindy. I'm a cardiac nurse, and I've been doing this for about 3 years. So bear with me as we kind of go through this and know that once again, this is training is geared currently towards paramedics bringing patients to Portland. But as we go through this, please don't hesitate to stop me and ask questions that might be related more to where you might be looking at the training. And I see some South Portland people on here, which is great. That's where I do have to give the disclaimer that I'm a paramedic's wife, so I do know a little bit about the paramedic world and you know, EMS and how it's just a different world than anyone else. So for some reason my slides, oh, because Eric's advancing my slides. Thanks, Eric. The objectives today are we are going to kind of go over the history of the AMI Perfuse program. We're going to look at how to identify a STEMI, the criteria. We're going to go through some of the appropriate inclusion and exclusion criteria for cath lab activation, direct access to the cath lab. We're going to talk about communication skills for one call remus and the overall of utilizing feedback reports from your field activation processes. Next slide. Next slide. Okay. This is just a little video that's going to go over the cath lab process. So I'm going to just hit this and let it play and we'll kind of go over it. Let me know if you can't hear it. All set on hearing it? Awesome. Any questions on that short video at all? One thing I do want to bring attention to is that it said that they went through the femoral artery, and we actually are going through the radial artery a lot more than the femoral artery nowadays. And we will go into that a little bit more in detail later on in the presentation. So that's just something to think about as you're working through with your patients and getting IV access. And we'll kind of review that a little bit as we go. So the AMI Perfuse program has been around for over 20 years here at Maine Medical Center. It was initiated in 2004 as a regional system of STEMI heart attack care. And the reason for its kind of conception was that in the late 1990s to early 2000s, stents became an important part of the cath lab, balloons and stents. Prior to that, we would use lytics a lot for STEMI patient care and hope that the artery would open, making STEMI mortality kind of high. But when we were able to get patients to a cath lab and get them to open the balloon and the stent, the mortality of STEMI care decreased dramatically. So at first it was thought of in the state of Maine, let's just put a bunch of cath labs around, and then patients will be at a cath lab within a timely manner. The thing that really happened with that is that they didn't actually think about the fact that there's a lot of extra training and equipment that's needed when someone is going to actually have a PCI, a percutaneous coronary intervention, versus just a diagnostic cath. And so they realized pretty early on that it would be more appropriate to actually work with the outside hospitals, the EMS systems, and get patients to a PCI capable facility in a more established and timely manner. So that is when the AMI Perfuse program was kind of born. So, and Perfuse stands for Patients Emergently Reperfused by Facilities United for STEMI Excellence. And so over the years, we've had a lot of cardiac saves, and we're just really been, it's been a great journey along. So, and that's just a little bit about the history of where we are. Any questions? So when we think about STEMI care, we think about the fact that it really, as EMS systems, you guys have two options when it comes to transporting these patients. You're either going to be transporting the patient to a STEMI capable facility, a PCI capable facility, or a PCI non-capable facility. Both are actually appropriate for patients, and patients are going to get reperfused depending on where they end up in the more timely manner. So the onset of the symptoms, patient calls EMS, EMS goes to the patient. We get a 12 lead, and our goal for 12 lead is first medical contact to 12 lead in 10 minutes, and then getting them off to one of the hospitals. Looking at where some of the people are coming from, are actually working within the people on this call. Brunswick's going to probably bring a patient right to Midcoast, which is totally appropriate. Their first primary level of reperfusion may be lytics at that point. And then some of the South Portland people definitely are going to bring them right to Maine Medical Center. And depending on, you know, what's going on with the patient and if the cath lab's ready, you may be bringing them right upstairs to the cath lab. And we'll kind of go over a little bit of that as we go through. Once again, any questions, you guys can stop me. I'm open to questions. This is just a little different look at the same thing. And up until recently, we really kind of worked as a primary activation service area, and we're kind of trying to get away from this. We're not saying that you have to be on this list to activate the cath lab. We are really letting you know that we want you to get the STEMI patients to us, if appropriate, as fast as you can. But these are the first areas of, or the first towns that we worked with to really build this program and allow for this program to get strong and to really show that. I think the thing that actually that we've found the best or the easiest, um, is that I think that cardiologists at first, when we first started to build this program in 2004, they didn't think that paramedics um, could could discover or could read a STEMI EKG. And I would say over the years that that has been proven wrong multiple times. And, I think that it's kind of like the fire service. You've got some of your older firefighters that believe one thing and the newer firefighters that believe another. We have cardiologists in the same world. And so we've kind of, I think, really phased out some of the older thought process cardiologists that didn't think paramedics had that skill. And all of the interventionalists now are really excited to work with paramedics and get the patients into the appropriate care. So when we look at our STEMI cases over this is actually 2023, we kind of stay about the same rate. We have on average just under 300 STEMI cases each year. This one was 361. Last year, 2025, I just did the numbers, just pulled them. I think it was 389 that we had, so we're up a little bit from here. And of those 361 patients, we had about, you know, 35% that were direct to main medical center and 65% that were from outside hospitals. So those patients that would have been, brought in by Brunswick to Midcoast and then transferred down, or those that are coming directly to main med. But the important part that I like to look at overall here is the amount of patients that are brought in by EMS. I do think it's interesting that the transfer hospitals kind of have a almost 50-50 private vehicle EMS, whereas direct to Portland, it's a little bit more on the EMS. But overall, we are seeing that EMS is higher percentage of our patients brought in by EMS, which makes it the reason that we really are working to partner with you guys on STEMI care and really build a relationship so that we can continue to give the best care to patients. So when we look at our metrics for what the best care is for STEMI patients, we have three very distinct goal lines or that we look at. The first one being first medical contact to EKG, so that 12 lead. So getting the 12 lead as soon as possible is always really important for us, so that we can know what direction this patient's going. Is this a STEMI patient? Are they going, should we be thinking that? For us, definitely time is muscle. And so the first medical contact device, when going directly to main medical center, the goal is within 90 minutes. And then those patients that may be going to like the Mid-Coast area, they're going to most likely get lytics, if they're appropriate for lytics, as their primary reperfusion strategy. Once again, we've done a lot of research, so it doesn't show that there's higher mortality utilizing lytics and then bringing them to the cath lab for open artery, like they had when they didn't actually get them to the cath lab back in the 1990s. So really it's the same kind of level of mortality no matter what. So just getting the patient to the right location is really important. And so our door-to needle, so meaning that if you are someone that's going to bring the patient to a lytic hospital, getting them to that hospital and getting in the hospital, getting the lytics in within 30 minutes is our goal. This is our cath lab checklist, and this is meant to be more of a guide versus a, have to check all the boxes. We really created this list to help you guys assess appropriate patients that would go potentially directly to the cath lab versus those that might stop at the ED for a moment or so. And even a patient that is completely appropriate for the direct cath lab, they don't always go straight up to cath lab. There are a lot of different factors that factor in that decision. Things like, is there an actual cath lab room open? Are there staff there currently? A lot of times, especially with South Portland, when you think about it, they're getting patients there within 20 minutes or so. And if it's 2 o'clock in the morning, we don't staff the cath lab 24/7. So we're having patients, not patients, I'm sorry. We're having staff come in from on call and they get a full 30 minutes. So a lot of times, you're probably, especially in the middle of the night, going to end up bringing those patients to the ED, being reassessed, stabilized if needed, and then upstairs. But some of the things that definitely hold patients back from going straight to the cath lab and needing a little bit more decision making are things like the duration of the chest pain. And we'll kind of go over some of that we'll go over this more in depth. Definitely, if the pre-hospital EKG is not a STEMI EKG, we'll go over that. If there's evidence of a left bundle or paced rhythm, that really does kind of, is that new? Is that old? If they're allergic to contrast dye, we're going to get them up there, but we need to give them medication first. If they've had any evidence of acute bleeding, any GI bleeding, any CVA issues, because we're going to be giving them a lot of blood thinners, we need to make sure that they're not going to bleed in other areas if we do give them that. So we want to make sure that we're assessing that. The way the patient plays a factor, because of the fact that the beds that are in the cath lab, we put the patient on a bed and then we move the bed around the x-ray. And those beds are really kind of, they're limited on how much weight can be put on them. This is, since we've moved to the new tower, we did upgrade the beds. So I think we're at 554 pounds now. But if you have a morbidly obese patient, it's definitely something that as you're calling into REMIS, you want to let us know so that we can prepare for that. And then, of course, if this STEMI is in the setting of a trauma, a lot of times patients will lose consciousness when having a STEMI. They fall, motor vehicle, what came first? Did they, have a STEMI and then hit the telephone pole, or did they have a STEMI after the telephone pole? Who knows? But the reality is did hitting that telephone pole cause any traumas? Let's do a CT first to make sure they're not bleeding anywhere else, so that we can safely anticoagulate them. And then, of course, is making sure that the patients are, hemodynamically stable. And we're going to go into a little bit with this. This is definitely not a 12-lead class, but this is the overall STEMI criteria for a 12-lead. And I hope that this isn't new for anyone, because this is definitely an important part to know. And this is really the part that you know, you guys do great. And honestly, the cardiologists have always been very impressed with paramedics looking at EKGs and letting us know. So overall, we want to know, is there, any ST elevation? Is it in two continuous leads? For V2 and V3, it's definitely dependent on sex and age, as well as does this patient have a new left bundle or a paced rhythm? Those are harder to tell what's going to happen with the STs. So that depends on how, if they're going to go directly up or not. Probably they're going to get another 12 lead before they go up. And chances are they're going to get another 12 lead before they go up anyways. But this is just kind of, the criteria. The one thing that we do like to mention here is that we'd like it if you could make 2 copies of your 12 lead. A lot of times, you bring in the patient into the ED and they're gonna take one of the 12 leads. But if you're gonna bring that patient right up to the cath lab, it's really helpful to have a second copy for the interventionalist to see as well. They're not going to have time to meet the patient, talk to you, go back to Epic, look at the EKG. They're definitely going to look at it as fast as they can, but it's much easier if they have a paper copy. I'm going to pause for any questions. You guys are a quiet bunch. All right, so this is actually one of my favorite slides of this whole presentation. And this talks about why it's important that we know kind of the symptom onset with our patients. If a patient has been having ongoing, true ongoing STEMI chest pain for over 12 hours and they're more of a late presenting STEMI, they may not go directly to the cath lab. There's a less chance that they would. And for those that would be bringing them into another hospital, lytics at this time would not be advised. So they may not be getting lytics in the same traditional way as a patient that has had chest pain for less than 12 hours. And the reason being is, if you can see here, the mortality of the patient is much higher at the lower end of the, so for the shorter hours, so it goes 0. So the hours are on the horizontal axis and the mortality is on the vertical axis. And so as time increases, the chance of mortality decreases and it almost plateaus at 12 hours. So if a patient's been having that true STEMI chest pain for longer than 12 hours, then what they will do for it, basically their heart has probably already had their full heart attack. And although they will, I'm sure, end up in the cath lab at some point, it may not be appropriate to bring them directly emergently to the cath lab at that moment. So it's important for EMS to help us with that assessment. And there are a lot of patients that have waxing and waning chest pain. So if a patient is like, well, I've been having chest pain off and on all week, and then but this morning at 6 a.m., it really started to feel like there was an elephant on my chest. Well, that's the start duration, is that elephant on the chest, or when it's really hurting the patient. So that's going to be when you want to kind of think about your timing on that patient. Any questions on that? Don't be afraid to come off mute.
They can't actually come off mute. I have to take them off mute.
Oh, you can't? They can't come off mute themselves?
Nope. They.
Oh, I
can
apologize.
if they ask.
Oh, I apologize. I didn't. This is I let me just put this disclaimer out. This is the first time Eric and I have done this way. So I didn't know the rules, and anyone that knows me, and there are a few people on here that do know me, they know that I don't live by the rules. So I apologize that I said to just come off mute. If they raise their hand, Eric, you can let them. Is that when you give them permission?
Yes, I can activate
Okay.
people specifically.
Oh, so, okay, I apologize. Apparently you have to, this is a more appropriate class that you have to raise your hand in instead of just yelling all at one time. So, all right. Well, good to know. Thank you. Sorry about that. So going back to access.
Oop, we've got a
Um,
question in the chat.
oh, we do. Okay.
At what point do patients not get sent to the cath lab at all? Greater than 24 hours?
So usually 12 hours will slow them down, Austin. So if they have sat on their heart attack for more than 12 hours, that then their mortality has decreased to a plateau. They're still going to go to the cath lab at some point in time, most likely, to get their artery fixed. But at 12 hours, their mortality kind of evens out, it plateaus. So we're not as crazy worried about getting that time as muscle kind of thing as the ones under 12 hours. So that's where you want to kind of do that assessment. Has it been a while? And once again, I don't think you guys would slow down per se your side of the chain of command, uh, chain of survival. There we go. Um, but it is going to probably play a difference on if the cath lab is activated or if the patient goes straight to the cath lab. Thank you for asking a question. So as we look at access for these patients, one of the things that I kind of alluded to is that we're using the wrist a lot more for access to the heart. So if you guys can avoid starting an IV in the right wrist, that would be ideal for us. We would love 2 18-gauge IVs. Anywhere other than the right wrist, AC is fine. We all know, I know, that paramedics can do IVs upside down, backwards, going 110 miles per hour. So we would much rather you get us an IV, even if it is the right wrist, if that's the only one you can get, than make us nurses do it ourselves, because you guys rock at IVs and we are not in general as good as you guys. So, but if you can avoid the right wrist, we definitely encourage it. And we're grateful when you A, get us some IVs, and B, avoid the right wrist. And one thing to kind of think about when it comes to access, when a patient comes to the cath lab, we are going to prep both their right wrist and their groin, so we don't have to prep their groins if we need to emergently switch to that area for access. So those of you that are really close in South Portland, you may not have time to be talking to your patient, but some of the other people, like I saw Gorham in here, you might have a few minutes to talk to your patient. And, letting them know that, when they get to the cath lab, people are going to be running around. It's a very, they're hustling in an organized chaos sense, but they will be prepping your groin and your wrist. I know that seems little and probably not something that you normally would do, but anything that we can give for information to these patients, I think really helps the patients. It helps calm them down a little bit. If you think about what they're going through, knowing information like that is really helpful. So, once again, appropriate for the cath lab. So when you're going to the cath lab, patients that are a DNR are not going to not go to the cath lab if appropriate. So what am I saying here? So we need to reverse any DNRs. So they will still potentially have that option to reverse a DNR. But if they are a DNR, we definitely need to know that, so that we can get that, that conversation started with them. If they have a lot of end-stage comorbidities, metastatic cancer, dementia, they don't want to be, intubated or wouldn't consider cabbage, we may not bring them up to the cath lab. Um, you know, it just may not be at the appropriate place. So once again, um, if you are not, granted access directly up to the cath lab, it doesn't mean that it's necessary your assessment. It could be something that they're realizing with the patient, and that we need to get taken care of or understood the goals of this patient's care in the ED before we bring them upstairs. As well as, can they tolerate the medications we're going to give them? These patients are going to be heparinized, they're going to get aspirin, they're going to have to be on Plavix for, many, many months. If they have any issues with those medications, it's not that they won't go to the cath lab at some point. It just may be that they're not going to go directly to the cath lab. Any questions on that? Apparently raise your hand if you do have any, because Eric will let you speak. Okay. So, you've got your patient. The patient has had chest pain for only 4 hours. They're not a DNR. They have a clear STEMI on 12 lead. And you want to bring them straight to the cath lab because you feel they're appropriate. Then what? And so at that point, we really, then you're gonna call Remus to activate the cath lab. So, and I say call if it's at all possible. I know that, in some areas of the state, phone calls don't work as well as radio. But if it's possible to make a phone call to Remus, that is the best way to get into Remus. And the reason being is that, Remus is going to need to get the attending to listen to your assessment. So as you're thinking about your assessment, you really kind of want to, start with, I have a STEMI, or I have a potential STEMI, and just pause, because at that point, then the person on the other end of the line at Remus or one call should be saying, okay, let me get an attending. We would much rather you tell your assessment clearly once to everyone that needs to hear it than to have to repeat it. And, it seems like that's just a small thing, but if you think about the fact that we only have 90 minutes to get these patients' arteries open, and we need a clear 30 minutes in the cath lab, and chances are you're, already potentially used 30 minutes on scene and getting them to us, every minute counts with these patients. So really kind of being precise and asking for attending right away when you know that you're going to be asking for the cath lab. And I don't know if I actually finished my sentence, but basically what I was trying to say is that if you're calling someone, they can get the attending on the phone with you, so it's easier. If you have to use the radio, that's fine. It just takes a little bit more time to organize the attending to listen to the assessment. Any questions on that?
Mindy, this would be where I'd probably add to that the attending knows why you're calling. So Remus briefs the attending right before they talk to them, and they know that you're calling for a STEMI. So you don't have to paint an entire picture for them. They're waiting for you to say, I have a STEMI, I want to activate. Here's the criteria that I'm using to activate. I have, elevations in V1, 2, 3, 4, wherever they may be, that they've had chest pain for less than 12 hours, just some basics. on that. It doesn't need to be a long spiel. Most of them understand what you're going through and what you're doing, so they'll go pretty quickly. We have cath lab activations that take 30 seconds, and we have some that people ramble for 20 minutes on the phone with them. So the goal that we're trying to get people to remember is be direct, tell them what you want, be polite, but that you want to do a cath lab activation, and then they'll get the wheels in motion for you. They may have a few questions, but those questions are usually very much related to your patient.
Yes. And if for some reason they deny you going straight upstairs, it's not on you or your assessment or your care of that patient. A lot of times that is related to other logistics that are behind the scene that you probably can't see, which might be things like we don't have a bed available upstairs, there's no cath lab open right now, or the staff's not in, things like that.
This
But with
may
that
also be a
being,
good time to add, every cath lab patient comes through the ED.
yes.
They have to stop at triage in the ED because they have to be banded, and they have to go up that way. And the attending will see them generally right near triage 5, if not sooner. And as Mindy added, the reason they get turfed into critical care is generally that the cath lab isn't ready to take them yet, is usually what happens.
Yeah. And that actually is a great point for this. If for some reason you don't stop at the ED, that can have huge devastating consequences. A patient needs to be registered in Epic before any orders can be put in. And before even the cath lab equipment can be turned on. So if a patient is not registered and you somehow get through all the security that there is now in the new building, up to the cath lab, then there's a chance that you may have to turn around and bring the patient back downstairs to be registered. I know that sounds very odd and crazy, but it's the truth and it's happened. So, even if you are clear to go straight to the cath lab, you'll need to stop, register, and be escorted to the cath lab. The new wing of the cath lab is now very much locked down, so it's very hard to get upstairs without an escort. Um, but so things to think about, every minute matters. Even if the patient is, you've had the patient in the back of the truck and you've been doing 12 leads on a regular, and you're, on the $1 million bridge, and you finally have an ST elevation and you're like, oh, I'm almost there, we can wait. No, definitely call in and get it started. Even if you're like on Munjoy Hill, I guess it's Munjoy Hill. I don't know. I'm not the best direction person. Um, but definitely call in. Um, you know, things to think about. The cath lab staff gets 30 minutes to come in from where they are. They definitely try to get here faster, but your call starts there starting. So we've had times where it's been a long transfer from somewhere, you know, let's just say 35 minutes away, and they don't call Remus until 5-10 minutes out, and it's 2 o'clock in the morning. And now we have to wait to get till the cath lab gets in to get that patient upstairs, and we miss the metrics, but also don't give the quality care that we are known for because of that timing. So the sooner you can identify it, the sooner you can notify us, the better we are overall for both the patient and everyone involved. And this is my cath lab stop on arrival. I feel like we've already really kind of pushed this one home, so I don't need to go here once again. Every patient needs to be registered before they can go upstairs, and it's very important that they are, so that the equipment actually starts. This is just a brief overview of those pre-hospital checklists again. If you're someone that isn't bringing patients directly to main medical center, this is still good to know, because they are going to eventually be coming to main medical center. So letting, the attendings know at whatever hospital you are bringing them to, some of these assessments are really helpful to them. And this is just a little open area. I kind of alluded to this earlier, that if you're someone that has a moment and you're kind of, the patient isn't in too much distress or isn't too, crashing too hard, um, and you have a moment, these are just some key pieces of information to keep in your head, that might help the patient understand what's going to happen once they get to the cath lab. If we can decrease their anxiety in any way, we're going to decrease their workload on their heart and potentially help them. So, things like letting them know that they are having the kind of heart attack that requires emergent treatment, and that people are going to be coming at them in all just different directions in a very quick way. And that is actually normal for this type of heart attack. And that's just people getting that artery open. If there's family that want to follow you in, letting them know that they can check in with the ED and that they'll be directed up to the cardiac intensive care unit. I guess it's down now. I don't know which way anything is in the new tower. I apologize. And so they'll be helping reach out with that information. So I'm not going to go over all these, but this is just an overview to kind of say, you know, questions that might help in that setting to relax patients. And lastly, this is just a quick preview of what we call a feedback report. These have been coming out throughout the channels, and we're working to get them even better to the EMS departments. And what we're looking at is that these are not meant to be punitive. They're not meant to show you that you did anything wrong. They're really as an improvement process. We look at every STEMI patient that comes into the hospital, and we assess how they did on their different times. And if there is a area that we can improve on, we just circle back and we talk to people. We only have so much information. We have what the run report says and what um, the chart says, and we may not know something. So one is, if it's not charted and we do find out that it was like a delay in patient care because of something that is not system related, we'd be able to make changes in our registry to help with that. But also, we really are working, because we're all working together as a team for these patients. And we want to make sure that we give the best care possible. So in order to do that, we want to give you the feedback of how well your call went. So you will be seeing these as we roll them out even more in the next year. So, but once again, they're not meant to be punitive. They are really meant to be helpful. And if you have any feedback from me, if you receive one of these on how I could make it better, that's the whole point of quality and process improvement, is to ensure that we, continue to evolve things to make them better. So I am happy to take feedback and love to get it, actually. The same with this training. If you have feedback for me, I am happy to receive it. I like to make sure that I am improving things as appropriate for those people that are really the key stakeholders of this information. So with that, we kind of went over, not kind of, we went over all of our program goals when it comes to critical timelines. We went over identification of inactivation, really kind of what patients are appropriate, and communication. So any questions, comments, or concerns right now? Okay, once again, I guess you kids can't just talk, so I apologize, but if you have any, please don't hesitate to raise your hand. From here, I will be working with Eric to send out, awesome, welcome, Michael. I will be working with Eric to send out, these slides as well as a follow-up email. Since you took this class, if you would like to arrange time to go up to the cardiac cath lab and watch, a few patients go through, then, I'd be happy to help do that, arrange that with you. We usually, have paramedics coming up on Tuesdays, and we do it in an AM and PM block. So it's usually, Tuesday from 8:30 to 12 or 12:30 to 4. And I will send out this email, or Eric and I will be sending out this follow-up email, and you can email me directly to let me know if you would like to come up to the cath lab. And if you do email me, know that my name on my email is Melinda, not Mindy, even though everyone knows me as Mindy. So I just kind of put it in there. It's melinda.buyer@mainhealth.org. Once again, you're going to get a follow-up email from me, and or Eric with that information. But if you want to email me directly, feel free and we'll get something set up. So, and once again, if you want to take a moment to let me know if there was more you would have liked or less, I'm happy to hear that. Once again, this is the first time we've done this more for the full state, I guess, than directly for people bringing patients to Maine Medical Center. And I think that we may need to evolve it a little bit. So I am open to feedback. Any questions?
Folks, the evaluation is also in the chat. If you could also complete that, please.
All right. If I have no questions, we will let you guys go. Thank you guys very much. Good day.